Welcome to today's episode of the Medical Fitness Podcast, powered by the Medical Fitness Association and MRF Institute. My name is Thomas Hammett. I'm the Director of Operations for Pinnacle Lifestyle Medicine and the co-founder of the Medicine Rehab and Fitness Institute. My co-host today is my friend and colleague, Jeff Young, kinesiologist and co-founder of the Medicine Rehab and Fitness Institute. How you doing today, Jeff?
Hey, I'm doing well. And hey, everyone. We are very excited to have Dr. Andrew Mock on our show today. Dr. Mock is board certified in lifestyle, preventive, and family medicine. He is the chair of the American College of Lifestyle Medicine's Fitness and Medicine Member Interest Group, co-medical director at the Center for Health Promotion, director of Lifestyle Medicine Residency Curriculum at Loma Linda University School of Medicine in the Department of Preventive Medicine, owns a gym in Redlands, California, and he is a super jacked, and I really mean that because I've met him in person. So he's a super jacked three-time California Strongest Man champion. Andrew, thanks for joining us. And to help us get started today, can you share a little bit more about your background with our audience?
Yeah, thank you for that, Jeff. And thank you both for having me on the show. Super excited about talking with you guys. I think like a lot of people in the fitness industry, it's that thing that I fell in love with growing up. So actually going through high school, I actually developed a lot of health problems with my stomach that ultimately ended with me dropping out of high school and getting my GED. And it was finding the gym that gave me a lot of focus. I was 14 years old and I started training and then never stopped. And I was loving what I was learning about my own anatomy, got more interested in the physiology, and then realized I love sharing that information. So it's like, what do I do to learn more about anatomy, physiology, and then also do some teaching? And that was what naturally led me to medicine. And then, all throughout med school, it was what can I do to talk to patients about exercise more? Because I just saw this gap, especially when it comes to resistance training in both the education that physicians were seeing as well as patients were receiving. And that's just been this forever guiding principle that's led to me to where I am now.
I love hearing people's origin stories, and I just learned something about you that I wasn't aware of, and that's really cool. And so yeah, and kind of related to that, and this will lead into our first question. You obviously are very passionate about strength training and helping to build this bridge between medicine and fitness, which was what this podcast is obviously all about. And something we've discussed multiple times, you and I and others, is our frustration with the current physical activity vital sign and the lack of emphasis on the strengthening component of physical activity. And for our listeners' reference, the physical activity vital sign is a screening tool that's used by healthcare providers to assess a patient's level of physical activity as part of routine care. It involves asking patients simple questions about their activity. The two main questions are, on average, how many days per week do you engage in moderate to strenuous physical activity like a brisk walk? And the second question that is the common question are, on those days, how many minutes do you engage in physical activity at this level? And then there's this optional question on strengthening, which is ambiguous, and I'll just speak for myself. In my opinion, very ambiguous. How many days a week do you perform muscle strengthening exercises, such as body weight exercises or resistance training? So, with that as a background, you and I are both passionate about this topic since strength training is so important, yet it's underutilized, underappreciated, and too often underdosed. So, as someone who really walks the talk, what would you want your peers to know about incorporating this third question into their practice to ultimately lead to patient engagement in this mode of exercise?
Yeah. I would start by saying if you're not asking these three questions, please figure out a way to make sure to incorporate them. I think we are moving towards this becoming a national quality metric that these will be assessed routinely at doctors' visits. I certainly have a lot of gripes about that third question and about how it doesn't really cover all the dose of the resistance training prescription. But I would say you cannot provide intervention for something that you don't assess. So if you're not currently assessing your patient's exercise habits in some way, then please at least start with these 3 questions. And then after that, right, purely by assessing, you've communicated that it's important. And then there's this whole other process of what to do about that 3rd question. So I think it's actually, what was it, Ashley Gutowski, some of her work that she did. People
Yes.
have no idea what muscle strengthening is. You ask them what will strengthen their legs, and they will say walking or swimming. And so we have a lot of work to do on that last question to make sure that we are actually getting people appropriately dosed muscle strengthening. And I think I'd prefer to call it something like resistance training. That way we're not actually just pigeonholing ourselves to the one adaptation, right? Because resistance training, there are tons of adaptations across multiple organ systems that are happening beyond just muscle strength.
Can we dive just for a second a little bit deeper into dosing?
Mhm.
And to the listeners, especially well, actually all listeners, but I was thinking in my mind about the clinicians and what does that mean as it relates to resistance training? You and I are getting ready to co-present with Mike Stack in a couple conferences coming up. So and our audience is going to be clinicians, and so we're obviously going to be diving deeper into that. But when I think of dosing, I think about the variables or the components that are involved in designing resistance training program. So for our listeners' sake, let's dive a little bit deeper into what do we mean by dosing, because ultimately that's also the big part of it. You want to ask the question, but you also have to be informed before you ask the question so that you can speak to your patients about what that means.
Yeah, absolutely. So the acronym most people will be familiar with is something like FIT-VP or FITT-VP, where it's frequency, how often, intensity, how hard, time, how long, type, what are you actually doing, and then the VP is volume and progression. And that acronym actually works pretty well for conditioning or cardiovascular training. And we get a lot of those components actually in that 1st and 2nd question of those physical activity vital signs. But that acronym doesn't work that well for resistance training, where we're probably wanting to get more something like volume of work, reps times sets times number of exercises done per muscle group with some sort of intensity factor. So sets need to be hard enough at an appropriate amount throughout the week. And I think, if you unpack the actual physical activity guidelines, muscle strengthening for all major muscle groups, at least 2 days per week at moderate or greater intensity. That one sentence, there is so much going on for how do you actually accomplish it.
Yeah, let's dive a little bit deeper because I teach a strength and conditioning course at a college here in New York City, and it's on Tuesdays, and this is today's Monday when we're recording, so it's tomorrow, and I'm going to be reviewing for my students the foundational principles of exercise, just which obviously relates to resistance training as well. I'm sorry, for resistance training, where things like progression, overload, variability, things like that. But I also have a slide on the FIT VP principle. And one of the things I want to mention and then get your feedback on is that I feel like that in this world that we live in, where people tend to get a little too caught up in the trees and they don't see the forest, that they don't realize that the FIT VP principle is real. It's a principle. It is a foundational principle that therefore we need to know it. And I think get the sense that in the world we live in, people will get too caught up in one, maybe a couple of those components. Like for example, I exercise 5 days a week, and so and therefore I'm consistent, etc. But there's more to it than that. You have to it like the way I look at it is in order for me to know that someone's on an optimal program, I want to see how they're addressing each of those acronyms, each of those components, and not
Mhm.
just one or more. So this is a foundational principle of exercise that we really need to know. What's your comment or feedback on that?
Yeah, and I mean, I think that highlights the problem with the current question, because all it's doing is assessing frequency and nothing about how hard it is, how much it is, or what you're even actually doing. And so the funny part is like, I don't know that frequency actually matters so long as you're hitting some sort of weekly volume. There may be some data that like the novice lifter will benefit from having more frequent training sessions, but once you move outside of that novice period, it kind of shifts towards weekly number of sets. And so, yeah, we have to figure out some sort of way. And I think this is actually a huge problem with exercise research is how do you even begin to compare study to study, right? They're all so heterogeneous because we don't have a standardized way to compare the dose to this study in this study. And so it's very easy for us to get these huge confidence intervals for the data because I can't really tell you if that person was working hard enough in a lot of the research we see.
Yeah. I'm going to chime in one more time here. I in this doctoral program I'm in, the course that I'm taking in right now is action research and kinesiology, and it's a little action. And I'm not going to get into this because it's not part of this podcast, but action research is a little. It's actually quite different than traditional research, and what I'm currently doing for this particular course is creating a like it's the research problem is actually related to what we're talking about right now, but specifically it relates to clinicians and they're referring successfully to fitness professionals, referring their patients. And what I'm going to be doing is I'm going to take two kind of what I believe are parallel concepts and merge them together. One is from a clinician standpoint, your standpoint. Step one is to categorize the patient into the appropriate behavioral stage categories. So in other words, you would determine through your, talk with a patient, are they pre-contemplative, contemplative, or in the readiness preparation stage? And that makes it the landscape a little bit less daunting because from a referral standpoint, because if
Mhm.
you already know they're pre-contemplative, then they are not currently a candidate for referral. And then you just take it from
Right.
there. And then the second part is the landscape is also daunting from there seem to be so many barriers to referral: time, finances, maybe previous negative experiences, chronic fatigue, chronic pain. We can go on and on and on. So if you look at the landscape, it seems very daunting. But if you break those down into their components and realize that the patient in front of you isn't going to have likely 20 barriers, they might have one, two, three, four. So we break those down, we look at the potential solutions, etc. But this is all backdrop to say that part of what I'm going to be doing, I'm very fortunate I'm currently working with some clinicians on this who are willing um, to collect data with their patients and then give it back to me for this project that we're doing. And one of those is to teach them about the strength part of this vital sign, because that's where obviously where it starts. The conversation has to start with the physical activity vital sign, and it has to be more than just two questions and then this ambiguous question on strength training. So I'm actually getting ready to have my own little mini research study, an action research study on this whole topic, and I'm really excited about it, to be able to get some feedback and maybe not only help my own practice a little bit, but also the field based on the data and the results.
That's awesome. Yeah.
Yeah.
I come back to this one and I think like we have to be realistic. What are people actually going to ask? And I think there's a lot of technology solutions with pre-visit questionnaires or digital health tracking, but those solutions are not there yet because nobody is really asking these standardized questions. And I tried to come up with like what was my absolute minimum for could I check a box and feel good about that resistance training vital signs? And I think it would be something like um, number of moderate or greater difficulty sets per muscle group per week. And so maybe you might argue, well, that's like 6 questions or however you want to divide it out for those movement patterns. But it would just at least be a number with some assumptions there. So still not what we would want, like if I was doing programming for an athlete, but I think a much better public health version than what we have here, which is just how often are you doing this activity that we don't even know if you know what it is.
Yeah,
It's really
absolutely.
interesting. I get really interested about the nuts and bolts of this stuff, Andrew. And I love that, what you were just doing there is assessing beyond like the actual assessment. You were assessing some literacy too, right? If you know sets and reps, you're probably doing true resistance training or some level of that. If you don't know what sets and reps are, we're not even getting into that probably. But I'm curious, this is really, again, I'd love to know the nuts and bolts, because I walk into an office visit with you, what is the assessment going to look like? And let's even just start with that subjective assessment, right? Of you're asking me questions to understand what my behavior is. Then I actually want to get into like, what do you do beyond that? But let's just start with the subjective side. What are you asking people literally in your office visits?
Yeah, so I'm big on culture, right? And culture driving behavior. So I like the phrase, this is what we do here. So every single patient that comes to see me, so I'm adult primary care with integrated lifestyle and obesity medicine. That's how I describe my practice. Every single patient that comes to me for every concern, we are talking about lifestyle medicine and how it is going to affect what they're facing. It doesn't matter if that's that true preventive visit, which makes a lot more sense to ask those questions, or that common cold, right? You better believe we're talking about the importance of physical activity for reducing your duration of symptoms by as much as 1 day with your common cold, and how to, use kind of like a symptoms guided selection of intensity to make sure that you're staying active and reducing your risk of complications for that common cold. So I typically start with a pre-visit survey that will have questions like this in it. And then I go a few different directions. So if I've already talked to the person, I know, what their exercise habits look like. Then a lot of times I'm just asking a very subjective, how do you feel about your habits? On a scale of 1 to 10, 1's the worst they could be, 10's the absolute best they could be. Where would you say you are with your exercise? And then they throw out that number, and whatever that number is, they'll say, okay, so maybe it's a 6. What's it going to take to shift you up to that 7 or 8? And so I love that, because I really didn't do anything, and already we've come to, here's the gap in our treatment based off the patient's perception, and then what they think they could do about it. And so that's, if I was going to offer one tool for clinicians out there, it's like, that's such a brief intervention. You ask them about it, and then ask their thoughts about it, and then ask what they think they can do about it. And if it's anywhere within your realm of acceptable treatment, I feel like my job is to do one of these guys, thumbs up to the camera, right? And say, that sounds great. Let's do that. But if I'm going through those questions, I see they're not listing any conditioning activity or not listing any muscle strengthening, I will actively ask about that. And then say, usually they're not lifting weights. And I would say specifically, are you doing any sort of muscle strengthening activity like resistance training, weight training, anything like that? And then get that yes or no. And come back with that follow-up question. Tell me about a time you've been more successful at exercising in the past if they're not currently exercising. So again, just kind of leaning on those motivational interviewing skills, supporting self-efficacy, their perceived ability that they can actually make change. So that may go into like, what are their needs? What are their barriers? What resources do they have? So it's a very personalized conversation. And I would say, if you haven't explored motivational interviewing as a tool in your practice, regardless of who you are, fitness professional, medical professional, it's such a powerful tool. And it really is the crux of like coaching, regardless of if that's the healthcare coach or the personal trainer coach.
Can I just real quick ask you both a question on this? As someone who's not a licensed clinician, and Thomas, it really wasn't until I met you and Sheila that I started to become, I mean, I heard of motivational interviewing and stuff like that prior to, but didn't really know what it was. And it was really the two of you who not only introduced me to it, but I started really learning what it was. I and then here, Andrew is familiar with it and uses it as a tool, and I know some other clinicians as well. But I get the sense, as someone who's not a licensed clinician, that it is not widely known and utilized by clinicians. So my question is, like, is that true, number one? And number two, where did you both happen upon this and realize that, oh, this is something I need to know better and use it as a tool for my practice?
Happy to answer first. I think it's getting better. I think it is becoming a standard part of
Good.
medical education where, just those general how to talk to a patient skills, it's involved early on. I'm certainly in a biased location. Our students get over 100 hours throughout all 4 years of medical school dedicated towards lifestyle medicine in some sort of way, right? But that's the culture that we've created. But even at my medical school that I went to in Georgia, those components were in there. And then it was just self-learning as far as actually improving those skills. But two great resources I would recommend. So what's the author's name? David McRaney's How Mind Changed. That's a great one. And then the Bible is Miller and Rolnick, Motivational Interviewing.
Yeah, I use that article in our training, actually, Andrew, that second article. So, Jeff, what I'd say, I actually think that at some level, like professionalism and maybe even we could say medicine almost conditions motivational interviewing skills out of people. Like the essence of motivational interviewing to me is to be curious and ask questions and to just view the person in front of you with some level of positive regard. Like they're telling you the truth and they want to solve their problem, and you are just someone who is there to help them solve their problem, right? And when we go through medical school, for me, PT school, what you're taught is you actually have to solve their problem for them at some level, right? And that's oversimplification and not totally true, but you need to be the expert at some level in your domain. And the second that you put the expert hat on, you, there's a way to do it where you take away all curiosity and it's just your job to say the right thing, right? Give them the right thing. And I think most people are inherently curious. To build motivational interviewing skills is just to go back to the root of like, let me try to understand this person, let me ask them questions, let me help them assess their readiness and confidence to make changes. To Andrew's point, and the reason that I care so much about like what kind of questions are we asking people, we have to have enough details about what people are doing to know, if they understand what we're asking them to change and do. I think too often, medicines are prescribed, or in PT, exercises are prescribed without really understanding what a patient's life looks like, and what they may be willing to do and what their first step of change could be. But yeah, I don't know. I guess that would be my answer, that I think most people, everyone has some element of motivational interviewing skills within them. It's like the resistance to fully adopt the expert hat in medicine that makes some people just hang on to that, I guess, better than others.
Yeah. And I think going back to add structure as far as the questions I ask, right? Everybody gets the screening questions, right? And then when they say, yes, I am actually doing something, then I have to dive into the details. And for resistance training, it typically goes something like movement patterns, right? Are you doing something where you push pull overhead, push pull out in front of you, a squat, a hip hinge pattern? And then I try to identify like what's their typical rep range for the sets that they're doing, how much volume of work or movement that they're doing, and then how do they know what weight to use and when to increase the weight.
Yeah, Andrew, when you got done, what with the initial question that I asked, what I was going to tell you is that, really in practice, you and I were practicing very similar, saying very similar things, practicing a very similar way. I tell every patient that I work with is going to go through the same process. We're going to take some health vitals and look at your health background, maybe differently than you ever have with a PT before. I'd ask every patient a question about how they feel about their overall health, more in-depth questions about their exercise, not just pertaining to their injured body part. Make it clear that the process isn't just to like fix your shoulder, right? Or to fix your knee pain. So it was really cool. You and I have never talked about the nuts and bolts of what we do in a subjective. So that was really cool to hear you describe. Let's go beyond that though. I'd love to hear. So I understand that you're doing more than just the subjective assessment in an office visit, and I'd love to hear what that looks like too.
Yeah, so objectively, right, so actually assessing someone's ability in office, there's two different versions of that. There's the much more time intensive version when I have somebody to help me, and then there's the realistic standard office visit version. I have a standard kind of clinic setup. There's like a chair that's usually across the room, and I'm over here tethered to the wall by my computer. And then there's an exam table that the patient's never sitting on when you come into the room. And so I could very easily do the awkward wheelie chair over to the patient, listen to their heart, lungs, assess them that way. But I tell my medical students all the time, I don't do that on purpose. And I ask them to move over to the exam table purely because I want to watch them stand up from the chair. And I think that is one of the single most important assessments that you can do is watching someone stand up from a chair. Because if it's very difficult for them to do that, immediately our test becomes the intervention, right? And we know what we need to get better at because I'm going to make this person a lot lower risk for falls if I can improve that sit to stand. And then at times, if there's like minimal hand assistance and they're going into a specific complaint where they're like feeling less stable or they have had that fall, then I might do a formal sit to stand and see how many times in a set time period they can stand up without using their hands. And I love the whole idea of testing being a teaching moment. So if I can do that in office and show them, hey, it looks like you're getting fatigued around like this eighth rep and it's slowed down. That tells me you've kind of hit that range where this exercise is hard enough. So if we wanted to do more, maybe let's add in some of the reps where you're using your hands more to stand up and then trying to use them on the eccentric or negative sitting down into the chair without using your hands. So just kind of while we're doing the test, right, providing some of that insight into the actual intervention.
Yeah, I love the 30-second sit to stand test as an intervention, like a quick assessment tool. If you Google CDC sit to stand test, there's a really nice figure in Google that you could find really quickly that tells you about fall risk for people of different age groups and gender. So it's a really nice tool. So you had mentioned something about if you don't have help, you might do what you just described. But it sounds like you maybe, when you do have help, you use a specific exercise test in your office visits. And I'm curious how you designed the exercise test for interval monitoring and how you use it as a teaching tool.
Yeah, and so the funny thing is why we designed this test. So we do some this executive help work where people want that additional level of screening and monitoring because maybe they're a CEO of a company and they don't want to have time. They don't have time to get sick. And so someone was requesting something like VO2 max and the functional movement screen as part of that. And yeah, this is actually just a increasingly common request for something like VO2 max. And yeah, it's certainly an important metric, but I don't know that I would recommend it for most people. Instead, right, just go do conditioning that's going to improve that number and not worry as much about what the number actually is they're taking the test. Right. So we had this request, VO2 max functional movement screen. And then I said, what do I actually consider functional? So I want people to be able to move through some arbitrary range of motion with these compound movement patterns against resistance. And so what we designed for the conditioning side is we have them do a submaximal talk sing test. And so they start out at a certain amount of work on like a bike or a treadmill, whatever their preferred conditioning modality is. And then we record their heart rate at set intervals, have them say a sentence, and then rate their subjective difficulty on a scale of 1 to 10. And we keep going like that until they hit that threshold where they can talk but not sing, or it's becoming more difficult to talk. And then we can track that heart rate over time of where it became more difficult to talk. And if they're on an ergometer, we can see like the power output, like the watts that they reach. And the reason I did that is so they'll know how hard they need to be walking or swimming or running to be at that minimum for how hard it should be for conditioning. So that, yeah, and a VO2 max doesn't really do that. You can certainly see on a graph where that first ventilatory threshold is, but it doesn't teach you that skill that you need to know for how hard it is. And then the second part is the resistance training piece. So the functional movement screen, I don't really consider those movements to be too functional because we don't really move that way in life for a lot of those movements. So again, I went back to overhead push pull, horizontal push pull, squat, hip hinge. I let the patient choose whatever modality that they're comfortable with, whether that's free weights, machine, band, or body weight. And then we find something that I think is a lot better than something like a 1 rep max or a 3 rep max. We have them find or estimate a 6 rep max. And so saying we, they're actually doing this with the personal trainer. So the personal trainer is able to provide some points of performance, which are a little bit arbitrary, but it's things like, hey, I want them to be able to start if they're doing overhead press, right, with the barbell pretty close to their shoulders, and then finish, right, with elbow completely extended overhead. Right? So it's just a very minimum, and then they grade it based off of, do they have pain with movement? Are they able to meet the full range of motion requirements? And so completely made up, but just based off of, hey, what would I actually want someone to be able to do? And the nice part is they just found their starting point. So they work with the personal trainer to estimate that 6 rep max. So now if I'm prescribing them one set of 6 for each set of those compound movements, they have some approximate weights to start with.
So Andrew, again, thinking about nuts and bolts and where this happens and how it happens, like, is this, I see you for my medical visit and I step out into a different room that has this equipment, or is this, I go to a gym where a personal trainer works with me to do this work, or is it a combination of both? Like, how does that look in
Yeah.
execution? This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.
So right now it's at the gym, which is a block down the street for me. If I'm perfectly designing the clinic, which is our hope for the next year, there's some great squat racks that can fold completely against the wall. And you can have the entire setup that you would need to do for this, picking up like 6 feet on a wall. It can open out when you have more space. And honestly, you could safely do this in an 8x8 open space. So that's the dream, is to have it in the clinic. And I think there's a lot of good commercially available options to get that equipment for any clinic for probably less than $3,000.
Yeah, I mean, and either way, I love the current model because you're getting people into the fitness setting. Anytime you take a patient away from your office and ask them to go somewhere else, there's going to be a reduction in compliance, right?
Yeah.
But I imagine, and there's benefits to that, like having someone show up in a gym setting and meet a personal trainer in that environment where they would actually be exercising long term, potentially somewhere that looks like that at least. There's psychological benefits to that if you can get them through the door, but to reduce the barrier to entry and get it to everyone, it's a really cool idea to have that happen in the medical office visit as well.
Yeah, absolutely. I mean, the whole part of the gym, and this is just one of my bigger thoughts, is people come to the doctor when they're sick, but they go to other places to engage and being healthy. So maybe we could go to places where people are engaging and being healthy and support them in that way as clinicians.
Yeah,
Well,
I love that.
PT actually does that a great job of that, being better integrated with like local fitness facilities.
Yeah, I think, I don't need to get on my soapbox about this, but I think we could always do better as a profession as PTs as well. It's certainly something that, I've taken a stand on in my professional career, is trying to be as good as possible at doing that. I'm really lucky to have worked at a group of clinics that has a fitness service line integrated within the clinic, but can always be better. I'd say just across the board in medicine, but yeah, it's great.
This discussion, A, was great to listen to, and B is a nice lead into my next question because you've been talking about the nuts and bolts, but I'd like to back up a little bit and higher view. Andrew, you've been working with the American College of Lifestyle Medicine for several years, developing continuing education on the strength training component of physical activity and exercise, which is being incorporated in medical schools across the country, which is unbelievable, and exciting. And yeah, I was originally going to just ask, can you talk about this as it relates to the role of physician and gaps in medical education? But I want to expand that a little bit, if you don't mind, because we've talked about this a little bit, but I actually am still trying to visualize, like, maybe A, how this got started and your role within this, and B, like, what does the curriculum look like? What are you doing? Maybe even what have you learned along the way, with things that you've had to change and modify and stuff like that? What's the ultimate goal here? And if possible, I know I'm asking way too many questions all at once, but if possible, it'd also be nice to actually bridge it back to what you and Thomas were just talking about, and the nuts and bolts, and what is like your perfect ideal vision as it relates to what you're doing with this, with this ACI.
Yeah. So on average, U.S. physicians, they get 1 to 2 hours of training in nutrition and exercise throughout all of medical school, right? So this is a huge gap that we're starting with. We're very good at taking care of health conditions, and then we don't get as much information on actually the first line treatment, which is going to be the nutrition, exercise, sleep, stress management, social connectedness, and avoidance of those risky substances. Um, and it actually just blew my mind when I'm in med school. And I'm just going to give a shout out to Jordan Feigenbaum and Austin Baraki, because I feel like these guys are just incredible with barbell medicine. They put out such amazing content. And I remember where I was listening to their first episode of their podcast that made me say, like, wow, somebody else is thinking about this of how do we get people to lift weights in the clinic, right? Or how do we get our patients to lift weights? And so it really just, I feel like it's a little bit of chance, luck, serendipity. I don't know what you want to call it, of just realizing that there's this gap, and it's also this gap in this thing that I love. And then, meeting some very influential people in lifestyle medicine. Brenda Ray, who is my mentor, great friend, former program director, kind of putting me into this position to kind of be the person to help fill this gap on the medical side. Um, it's very interesting with American College of Lifestyle Medicine. We're working our way back, right? So we're starting with practicing physicians. Now we're working into medical education. But I feel like these are fundamental principles of life, and we just need to keep going even further back. We should learn how to do resistance training in primary school, elementary school. Certainly, what that looks like needs to be very different. Us stuck up adults, right? We go to fitness facilities to do our exercise, but kids are much better about having fun with what they're doing. But I mean, I don't think these concepts are particularly hard. I do think that everyone should know them much earlier in life, far, far sooner than medical school.
Are you aware of
Yeah,
how many medical schools are incorporating this at this point?
it is exponentially growing. So just thinking about residency programs, when the lifestyle medicine residency curriculum started, my institution at Loma Linda was one of 4 pilot sites. And I believe we're going to have this year over 500 residency programs across the country. And so for me, that's super exciting because actually, when we did this version 2.0 of the curriculum, there wasn't a resistance training lecture in there at all in version 1.0. It just kind of talked about the guidelines, but not actually how to do it. And so that's what the 1.5 to 2 hour session provides. It's an asynchronous online module, and they actually learn how to do it. So they go through all of those components, how to assess them, what is the recommendation for prescribing them, and then a big emphasis on like the practical applications, which is like, let's make it simple. Like you don't have to remember an exercise for every major muscle group. Can we break it down into those 6 compound movements and just give you a simple framework that will provide the most bang for the buck for the most individuals?
How do you feel like it's been going since you've been doing it? In this, let me be a little bit more specific. Obviously there's going to be a learning curve with the audience in front of you, where some have experience with this and it's, they're grasping things right away, and with others who don't, need to be taught what a rep is and a set is and stuff like that. So I'm curious, like, from that standpoint, like, what modifications have you had to make? How do you feel like it's going? Is it heading towards being ideal, or do you have a lot more work to do? Things like that.
Yeah, there's certainly always more work to
Yeah.
do with it. I think it is getting better. You know, one of the biggest barriers I feel like for the resistance training piece is perceived lack of safety, that it's dangerous.
Yes.
And so it's been really kind of breaking that down, even like amongst our own people, and saying like, oh, we don't know if we can do that. I'll just give an specific example. Even with the seminars we're doing with ACLM, as well as from nonprofit organizations, and even my own institution, the conversation is, oh, we don't know if we can allow that workshop to happen because our liability insurance might not cover it. And then, of course, they get this onslaught of data coming from me saying, like, what are we concerned about? Like, here's the consequences of not lifting weights. Here's the actual risks that we're aware of lifting weights. And oh, by the way, right, you're playing tennis, pickleball, soccer. Guess what makes that safer, right? Your kids are playing football. Guess what makes that safer? It's lifting weights.
Yeah. Well, I love that. I mean, obviously that you're doing this, I think is amazing, and I love to hear how much it's expanding. And I just hope that, like, is this something that you feel like, are you locked into this position with the ACLM that you're going to be helping to lead this for years to come?
Yeah, I mean, that's the goal. It certainly is a need. I think there is um, I guess a very big personal growth in realizing that you actually don't have to do everything. There's such a huge need with this area that I feel like I could only focus on providing resistance training workshops and just teaching people how to lift weights for themselves and how to help their patients lifting weights, and could make an entire very fulfilling career out of that.
Yeah.
And if
Well,
I ever ran out of work, that would be the most amazing problem to have, because that would mean that everybody's lifting weights and teaching their patients how to lift weights.
well, I want to keep being your colleague on this, Andrew, without a doubt.
Yeah, and that's a really nice segue, Jeff, that you guys are colleagues and work together. And that's, Andrew, one of the questions I wanted to ask you, I think it's obvious that, physicians are going to work with medical assistants and nurses and PAs, et cetera, right? But I know you work with other providers or professionals closely, and I'm curious if you could share who those professionals are and what kind of work you do within this network of providers.
Yeah, absolutely. And this is a big challenge that we're facing, right, with actually being able to provide physical activity interventions, is the system is not really built to enable that to happen. Physical therapy is probably the best case situation because it's paid for and covered by insurance, but it still comes with a cost. And so one of the challenges I had when I started at this institution is we didn't have that good physical therapy connection. So I sent an email. I showed up to a local practice and I made that connection. So now I have my trusted people that I'm saying, hey, I need to send this person to you for overall muscle strengthening, or better, like a graded exercise exposure program for conditioning. Can you help them do that? That way we can transition them to a home exercise plan. And so actually with our academic-based physical therapy practice, we developed a sarcopenia and physical deconditioning referral, which is literally that. They work with them 1 day a week, and they're either doing compound movements or they're on a progressive conditioning program. And so it just kind of took going and making that connection. People loved the idea because they kind of hated that they were always forced to be pigeonholed. And that's probably the biggest note that we can take away as clinicians, is physical therapy is limited by what we tell them to do. So if you want them to do more, make sure that you're providing that uh, information in the referral. But I also have that local physical therapist that I know is going to take extra care for the athlete. They're very big on like the biopsychosocial model of managing things, right? So they know how to manage that mental aspect of the athlete. Um, but then it gets a lot tougher, because what do you do for the person after physical therapy? And really, I just have my local network of personal trainers. So, like, I know that Greg, um, and Mark and Cindy all have their different qualities. And so I always have that in the back of my mind. So usually it's location where they are is one of the first things. Affordability by the patients is another big thing. And then it's right, how do I feel like they would mesh with the patient in terms of their goals, personalities, and things like that. So it's tough because personal trainers, they don't use our same communication system. So there has to be that kind of navigation for figuring out how to get around those communication barriers. So we're currently working on it right now, and actually trying to apply for an ACSM EIM grant to see if we can improve our hospital-based referral to the physical therapist. But they're the ones that are currently doing the exercise testing for me. And so, yeah, very hopeful for that one. And then, I mean, the dream would be that they have the electronic medical record, the actual gym, but that would, yeah, certainly some barriers to doing that, especially cost for sure.
I I really appreciate the example that you gave related to sarcopenia with physical therapy. I think a lot of people, particularly referring providers, think that that you need to be hurt to see a physical therapist, and that's just not necessarily the truth. You know, the insurance payer system kind of makes it seem like you need to be sick or hurt to see any medical provider, right? The other rehab or exercise that's covered by insurance is, you know, cardiac and pulmonary rehab in particular. And again, you have to have had a cardiac event or a progressive pulmonary condition to have those covered by insurance. So it does feel difficult to get patients in if you kind of take it at surface level, but PTs can see people that aren't necessarily just hurt or going through surgery. I really love that example. And again, you know, if I have to get on my soapbox here, it's that PTs should recognize their role in, okay, we can get people started and do the testing that you're talking about in an effective way, but the long-term plan has to look like long-term adoption of exercise. And the fact is that most people need help for longer than what physical therapy can give them. Let's be a really good, supportive, positive starting place for people. But then, you know, as a PT, we have to advocate for ourselves that we get those patients. It's not like we need the physicians to tell us necessarily that we can see them or not. But, you know, on the other end, it's then we we have to we have to finish that pathway. You know, we have to get people from us into exercise long term, and that means getting them to exercise professionals. And again, I just really appreciate you sharing that. It's such a good example of where I think, you know, again, at surface level, if we take what it appears to be in medicine, oh, you're not hurt, you don't need to go to PT. That's just not a very creative use of what is allowed, and you know, at the highest level of our credentials. So it's great. It's a really good story that you tell.
Yeah, and I mean, I think Thomas, this is all part of this big dream that I have, and we can laugh about the name in a moment. But my goal is to develop um, the physical activity network from the ICU to the home exercise plan, right? So what am I doing to reduce your inactivity in the hospital where 95% of your time is spent in the bed or the chair, right? And almost everyone is coming out of the hospital weaker. So what am I doing to reduce that? And then, right, transitioning to acute rehab if needed, physical therapy if needed, the fitness professional versus the self-directed plan or the exercise program, and then, you know, the home exercise plan. So my dream is to call that the pump protocol. You know, doctors love their acronyms, and I said picking up muscle protein. So if somebody feels that, I'm not going to be unhappy so long as that, you know, system is actually in place. But
It's official here that you coined the term no matter what.
yeah, the
Exactly.
pump
Yep.
protocol.
That's
Exactly.
great. I love that.
All right. Well, as we begin to wrap up today's episode, I do have one more question for you, Andrew. Um, I learned through a previous mentor of mine that the combination of being a physician, a strength athlete, and understanding rehabilitation from both a personal and professional standpoint gives an incredibly important and wide perspective. Similar to this mentor, you know what it's like to suffer serious injuries and then rehab back to the elite level. And having gone through this process more than once, I'm curious, what are some of the things you've learned that you think would benefit our listeners to know?
Yeah, absolutely. And so just a quick personal medical background. I tore my ACL in my very first pro contest broadcast on ESPN, and you can hear the pop on the video when I'm
Wow.
doing overhead clean and press.
Wow.
And then about a year ago, I actually had a rare complication from a viral illness, developed something called Parsonage-Turner syndrome, which left me with like a lot of weakness in this left shoulder and bicep. So it was actually like partially paralyzed for about 3 weeks, and then it gradually got better. But the big challenge with that was not so much the weakness, but some of the constitutional symptoms like dizziness when I would change position. And something I still have challenge with is like post-exertional malaise. So if I have a hard training day, I feel like I've been ran over by a truck for 2 days. So kind of fits within that chronic fatigue syndrome spectrum. But the thing that I would start with is something's hurt. Remember that there is an entire rest of the body that still needs to be trained, right? So we should prevent detraining of everything else. So if my arm's broken, I've got 3 other extremities and heart and lungs that work great. And actually training those will improve the outcomes of that affected extremity. So we want to make sure that we prevent detraining. And very importantly, we want to make sure that people who are athletes still feel like athletes, because that can be a huge mental challenge when you identify as an athlete and now you are hurt, right? So give them something to do, give them something to work towards, and treat that mental process as much as you're treating the actual physical injury. But I think the thing that I learned the most about is just really activity modification in practice. So all the different ways that I can modify range of motion, intensity, exercise selection, and volume to adjust to what's going on. And so, thinking about dizziness, like how do you modify exercise for dizziness? So what I actually did is I realized that it was the range of motion of my head that triggered the dizziness. So it didn't matter what weight I was deadlifting. If I bent down far enough, I would get dizzy. So I just tried to bump up against that threshold. And so I started with elevated deadlifts, and I'd allow myself to get up to like, I don't know, making this up, like a 4 or 5 out of 10 dizziness. Like I would get close to it, engage it, and then hopefully try to desensitize myself to it. And then over time, I just progressed that range of motion until eventually my head was going below my knees because I was doing a 9-inch deficit deadlift, trying to still make myself dizzy so I could get this out of there. And so, yeah, just thinking about how you can modify those components to whatever somebody is dealing with can be really helpful. But yeah, and let's see. And I would say the other big principle is just kind of that symptom autoregulation. So we have this threshold of acceptable symptoms. We want them to kind of engage towards that threshold, but hopefully not go past it. We especially don't want them to not tolerate the exercise and make things worse 1 or 2 days after it. So we're not talking about delayed onset muscle soreness, but I don't want to make your chronic pain symptoms worse. And those can be tough things to figure out because it's very individualized, but certainly going through that myself has really kind of helped me understand what that looks like and, how to communicate it better with patients. So silver lining in all things. And I say that's probably the best silver lining that I've had from all of that. Thomas can correct me on any of my rehab principles.
No, you were great. You were great. Yeah, I'm just reflecting on the question myself because I think it's a good question, Jeff. Trying to even figure out where I would start with this. The first thing that comes to mind, and I talk to this or talk to PTs about this all the time. I think like in college athletics, athletes and professional athletics for that matter, but it really starts in college. Athletes get all the resources to be successful, right? They get all the resources to optimize their health alongside, if you get hurt, you've got a nutritionist that can still work with you. You've got a, strength and conditioning coach. You've got therapy. You've got a coach of the team that's going to coach you. And there's so many resources that I think just being involved in athletics, are possible and available that, I think those who have not interacted as much with athletics don't think about how much you can optimize beyond just the rehabilitation itself. And those, nutrition is still important for someone, even if they're not going to be, lifting hundreds of pounds athletically for competition, or throwing a ball as fast as they possibly can, or tackling somebody, right? Like, we can still do a lot of things to optimize recovery beyond the rehabilitation itself, the rehabilitation movements, what we consider classically to be rehab, which may look like a lot of different things depending on your exposure to it. But I think just the lens of knowledge that people can benefit from more than just that part, and that there's a lot of power to that. I had a second thing and I'm forgetting it now, but I think that perspective it's something that you just get by having gone through athletics, whether it's yourself or like as a coach, or yeah, as a physician for a team too. So yeah.
One of the things that, as it relates to things that both of you have been saying, not just recently, but throughout this podcast, that this particular physician that I just referred to, and even though it was common sense in hindsight, I still kind of need to hear it. And that is, there is a pathway, and this pathway applies to, in one way or another to everybody. And that is, first of all, we live in a country where unfortunately most people are not meeting the minimum guidelines for physical activity and strength training.
Mm.
Therefore, most people are uh, on the weak and deconditioned side of the spectrum. And so he just seemed to get it more than most of the I'm just talking about my own experience and perspective, but he just really saw the importance of moving people through the medicine rehab into the fitness domain. He saw the importance more so than others of the importance of strength training. And not necessarily, it doesn't have to be to get you to the advanced or elite level, but to get out of that beginner range and stuff like that. So even though I was seeing it in the system I was working at the time and stuff like that, I kind of just needed to hear it from him, that how important, and just hear it from a physician where I hadn't been hearing it from this prior to him, the importance of moving people through the whole pathway, getting them onto at least some sort of physical activity and strength training program, etc. And so, and he just got it more so partially because of he was an athlete and had been injured before and stuff like that. And one other thing, Andrew, that you said
Mhm.
that I think is great, that may be a little unrelated here, but I want to at least touch on, is how, dosing and how amazing the body is at adapting. Like, you used the head, the neck as an example, but finding that spot where you just hit, that point where your body's saying, "Oh, you better watch yourself," but you get it there, and then slowly but surely your body's going to adapt to it. And that is absolutely my kind of summarizes my approach to post rehab, is finding that the capacity, what they're able to do with whatever that means, and then and testing it a little bit, knowing that the body is going to adapt to that stimulus, and then improve and move beyond.
Yeah, I have one more thing I want to add to, because Andrew brought up a really important thing that I think is so often missed in rehabilitation programs for the general public, which is the idea that you can rehabilitate more than just the body region or impairment that you're being seen for, right? And you can, or maintain and optimize your fitness for those areas that are not currently hurt or going through surgery. And I think we just miss that, man. In physical therapy, if we're going through the insurance payer system, you're being paid to treat the impairment, and anything outside that is kind of like extra stuff that's not related to the plan of care. What we do at Pinnacle to get around that is, I refer to a service called Bridge, which is with a fitness professional. So while I'm working on essentially what's owned by, my plan of care, let's say it's the shoulder or the hip, that we've got a rotator cuff injury, for example, that, there's benefit to that person getting more exercise than their baseline level for the rest of their body. And I can start that conversation before rehab is over. And that's when I refer to that service, right? So it's a really important point you brought up, Andrew, that I think is it's just super valuable with regards to this conversation. And I think it's cool that you've got that lens too from your position in medicine.
Yeah, absolutely. I mean, we have one of the guys in the gym right now, unfortunately, just tore his bicep, and the second it happened, I was like, you realize that we are gonna work your legs and your right arm so much harder right now. since you're not going to be able to stress that left side. Because, I mean, what's the worst case scenario? You turn out looking like that, oh my God, weird pop culture reference, the guy from Lady in the Water, like the protector that only trained like one side of his body. And it's like you just have this super jacked right side, and then your left arm catches up once it's done healing.
That's real, man.
I have a quick question for both of you. About 13 years ago, I lived in LA for about a year, and I was working at a private practice called Westwood Physical Therapy. And similar to the Bridge program, we called it a treat and train program. And but it was the same thing where the physical therapist would be treating for a certain issue, but whenever possible, I would train that same person, and either work around it or whatever. And so my question to both of you is, because I don't know if this is anecdotal or if there's data on this, but it just seemed like they also were healing a little bit faster or something, for lack of a better way. So is there any data on this, or do you get the same, or is this something the placebo and I was just imagining it? Be honest with me.
Yeah, no, there's definitely data, right, that continuing to train other parts of the body will actually improve recovery.
Okay.
I remember like the most mind-blowing thing to me, at my med school, there was this basic science researcher. He gave mice strokes, simulated strokes, and then he blew up a blood pressure cuff on one of their extremities to kind of simulate the metabolic stress of the exercise, right? And by doing that blood flow restriction training, he was actually able to shrink the amount of that stroke that did not recover. And so that to me was just like this, man, there is something being released by this muscle as it's being exercised, or that metabolic stress is increasing, that is going everywhere. And when we look at like the cancer mortality and morbidity reduction, and like all the thoughts about how the muscle as an organ system is playing roles in the immune system, it has to be through those myokines that are going everywhere in the body and not just that muscle that you're working.
That is so cool.
And I'll just tell you anecdotally, because Andrew cited, he cited the research, and I'm glad that he did that, because I can now tell a story and I don't have that burden now. But the patients that I see, they are, that continue to be physically active, they do participate in bridge and exercise. They're, it seems so simple, but they are continuing to use their bodies. And you'd be surprised how many people recoil from physical activity completely because there's an injured area. And I get it, man. It stinks to be hurt. It stinks to be out of the game for whatever reason. It stinks to be dizzy. It can be debilitating, but if you continue to use your body physically and challenge yourself, it's just part of our human experience to get up and move. And psychologically, it does a ton for us. Those patients that continue to be physically active are the ones that I find to be the easiest to rehabilitate and that enjoy the rehabilitation experience more. So yeah, I think there's definitely something to it, for sure, Jeff. Yeah, so we're out of time, Andrew, but I'd love, before we wrap up, if you could just tell us where our listeners could go to learn more about you.
Yeah, I mean, so most of the effort that I do is through American College of Lifestyle Medicine. So we put out a lot of educational material through there. And then we'll also have a resistance training workshop that we're doing in December with Medical Fitness Association at the national conference, as well as a repeat one. I think it's going to be in April of 25 in Asheville, North Carolina, with American Academy of Family Physicians. So if you want like the hands-on experience, teach me how to lift weights so I can teach my patients how to lift weights, those are the best options for you. Outside of that, I mean, Instagram is largely, I guess we'll call it an athletic page, dr_MOCK. So just be fully prepared to see me as a strongman athlete and less as a professional doctor. Let's say it that way. In other words, my shirt's not on a lot of the time for that. I live in Southern California. It was 110 degrees over the weekend. So, yeah.
Love it.
Well, thanks so much, Andrew. It's been an absolute pleasure. Thanks so much for what you're doing for the medical profession, the work you're doing with the American College of Lifestyle Medicine, just everything you're doing to incorporate exercise resistance training into medicine. It's inspiring for us. And I appreciate you sharing some time with us today.
Yeah, absolute pleasure.
Andrew, thank you. I look forward to seeing you in a little over a month in Orlando.
Yeah, it's going to be great.
All right. Take care.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Attention, all medical fitness professionals. Get ready for the event of the year. Register today for the Medical Fitness Association Annual Conference, November 19th through the 21st in New Orleans. Network with industry experts and like-minded professionals from around the U.S. and Canada. Gain insights from leading voices in medical fitness and take your career to the next level. Don't miss out on this incredible opportunity. Mark your calendars for November 19 to 21st and join us in New Orleans for the Medical Fitness Association Annual Conference. Register now at medicalfitness.org. That's medicalfitness.org.